Okay, psychodynamics here. Now, if you're not psychodynamically inclined, then you can take this with a grain of salt, but it's worth considering. One thing that's at the heart of the experience of PTSD is a profound sense of powerlessness, okay? And not only powerlessness in the midst of being raped or a natural disaster, but also powerlessness to control the symptoms, which are like intrusive memories and so forth. When prescribers come in, and maybe they have good intentions, but they are too aggressive in giving the medication, and it changes how a person feels, especially if it causes lots of sedation or other side effects, this can be perceived as also something being done to them that they can't control. Does that make any sense? This may be conscious or it may be unconscious, but we have to really keep in mind that at the heart of what we want is to restore a sense of control. And so we have to be very thoughtful about the approach to using medication treatment. So there's sort of the psychodynamics of, treating the person. Now, in the early days, before anything was really understood about this, especially in World War II, they had what they called traumatic war neurosis, and eventually became PTSD. People, especially that were in states of wild agitation, panicky, flashbacks, nightmares, it seemed like the best thing to do would be to put a lid on that. And so back in World War II, they used barbiturates and they used valerian, which you can get in health food stores, and it would knock people out because they didn't have any other choice. In the 60s and 70s, they started using antipsychotics, they started using tranquilizers. Again, it seems like we have this overwhelming anxiety, maybe that would be a good thing to do. It turns out, though, that those approaches not only don't work, but can make things worse, okay? Now, this is from Edna Foa, but this is at the heart of behavioral treatments for PTSD. The American Psychiatric Association has on their website practice guidelines, and they say emphatically psychotherapy is the treatment of choice for PTSD, and that there are two kinds of psychotherapy that have been empirically validated, and mean there's been enough studies to really establish them as being effective. Number one is exposure-based cognitive therapy, and number two is EMDR, which got on their list 2 years ago. Okay. Now, Edna Foa was one of the first originators of exposure-based cognitive therapy for PTSD. And what I want to do is I want to read you this, highlighting a couple of aspects of what she says, and then talk about how medication can play a role to help facilitate recovery for PTSD, keeping in mind psychotherapy is the treatment of choice, okay? Now, at the heart of exposure-based therapy is this: to help to facilitate the cognitive processing of the traumatic events and construct realistic, organized memories of the events. Ultimately, this is what's at the heart of this therapy, is getting the person to tell their story, but this has to be done in a way that is extremely gradual. This is where this is the big problem. This must be done without re-traumatizing the client. And I mentioned before that in studies of PTSD, dropout rates after the first session oftentimes are between 25 and 50% of people drop out of therapy. And this is in therapies with people who are good therapists. And sometimes simply saying something as seemingly benign as, "Can you tell me what happened?" or "What was that like for you?" can take these people from 0 to 100 miles an hour in a split second. As they begin to recall and think about the traumatic event, they quickly get completely overwhelmed, and then the psychotherapy becomes traumatizing. And guess what? They drop out of therapy. Okay? So the trick then is, eventually it's going to be important to be able to bit by bit gradually put the pieces together, process what has happened with the therapist, but it needs to be done in a very gentle way. And so as research suggests, as memories become more organized, there's a decrease in PTSD symptoms. Now, there are basically two ways to do this. All right, one is to use non-medical approaches. And that certainly can be very helpful. And here's what you would do. The person comes in, and you've determined based on their symptoms, and you get a little bit of history of what happened, but not a lot, okay, just a little bit, because you don't want to drive them away from therapy. Then is to say, okay, now I want to tell you what, you have PTSD, post-traumatic stress disorder. This is not rare. It's actually a very common reaction to extremely severe stresses. And I'm going to recommend an approach to therapy. Here's what it involves. Ultimately, it's going to involve having you and I take a close look at what's happened and talk about it. But I want to tell you something, and that is the research is very clear that this cannot be done in a rapid fashion. You can't jump into the deep end of the pool unless you can swim. So what I'm going to strongly recommend then is that for the first month, or maybe longer, is that we're not going to talk directly about the rape or witnessing your child killed in a car wreck or something. What we're going to do first are two things. One is I'm going to teach you some very effective anti-anxiety techniques, anxiety management techniques. And we're going to practice those again and again and again. Because my guess is you know that when you start having these memories or these flashbacks that they feel overwhelming, I want to really help you become an expert at being able to rapidly and effectively turn down the volume on these intense feelings. And it's not until then that we'll begin to talk about the traumatic event. Now, I'm going to tell you something. Every person I treat with PTSD is looking at me like, oh, thank God. Because anybody they've talked to, they easily get overwhelmed. It's just too much. It's like they say, God, you get it, don't you? You know what this is like, don't you? The other thing is we can talk about problem solving and coping with daily life between now and when we start the discussion of the traumatic events. Okay, and so a lot of effort and energy then is put into helping them develop these potent anti-anxiety techniques. The other thing that can be done, and they're not mutually exclusive, is to say there are medications that can be used that once they're working and they're on board will help you on a biological level feel much more solid, so that when we begin to talk about some of this stuff that's really frightening, you're going to notice it's not going to be as overwhelming. You're going to be able to have better control. Okay, and so you may have a psychological or a medication approach to helping them stabilize before you begin the exploration. Is everybody with me on that? Now, let me just say one more thing, and then we're going to take a break, and we'll come back and look at the medication treatment. There are some people, and I've seen a couple of these people, who are going to come to you, and these folks are not high functioning. Prior to being raped or experiencing some other kind of trauma, it's clear that they've been marginally functioning in terms of their ego strength. These are people that may have chronic, like borderline personality disorder, and then they get traumatized on top of that. Some of these people, they are never going to be sturdy enough to really process the event. Okay, and this is not a personal opinion. This is just what the experts say about this. For these folks, the focus is not on reliving, thinking about processing, putting the pieces together. It's about staying afloat. And so most of the therapy then is going to be geared at dealing with day-to-day living, anxiety management, and medication. And if and only if they get to a place where you feel like they're sturdy enough, might you begin to talk about the traumatic events. It's a very, very high-risk kind of treatment to do because of the high dropout rates. Thanks to neuroimaging technology, there's a lot more known about the brain now than even 10 years ago. And one thing that happens in cases of extreme anxiety in general, but also where you get this in a very pronounced kind of way, is with PTSD, is this, shutting down the language center. Now, the way that this has been studied is they put people in a SPECT or PET scanner, and these are people who have PTSD, and then they trigger anxiety. And the way they do it is they use a script-driven trigger, which is usually a paragraph that is extremely descriptive of the horrible event that the person experienced. And it's something that's put together usually, most of the time using the patient's own words to describe being raped or whatever the bad situation was. And so then they've got this already prepared. They put the person into metabolic imaging, and then they read the script-driven trigger, and just without exception, people go into these states of extraordinary anxiety. Sometimes they have flashbacks, but if nothing else, it leads to very extreme anxiety. And of course, there's all kinds of things that happen metabolically in the brain during this time. But one thing that's really very interesting is that for some reasons that it's not well understood, but it happens, is there's a significant decrease metabolic activity in the left hemisphere during the states of extremely severe anxiety. So, and this matters, and I'll tell you why it matters. This is the left hemisphere, of course, as everybody knows, is for most people the site for language processing. And so when you metabolically deactivate or unplug the left hemisphere, then during this state of very severe anxiety, people lose the capacity for thinking clearly. All right? Now, a lot of times when people are very anxious, their ability to maintain perspective is a significant coping ability. It's like, okay, I'm feeling really anxious now, but you know what, John, hang on, this is probably going to go away in a few minutes. You're going to feel a little bit better. Oftentimes at the heart of cognitive therapy for panic disorder, people learn to be able to maintain some degree of perspective. I know these panic attacks only last about 5 minutes. Hang on, it'll be over in a few minutes. But if you completely lose the capacity for critical thinking, then what it does, you don't have that as a coping source. But also, it scares people. They start feeling crazy. Because it's not just the ability to hear and interpret speech and to produce speech, but also in the temporal lobe, Wernicke's area, is where language organizes reality testing. And so people start feeling like they are disorganized and they can't think. And of course, if you're in the midst of feeling overwhelming anxiety and you start feeling crazy, then that just throws gasoline on the fire. Okay? Now, I had this really great opportunity once. I had a psychotherapist who was in therapy with me who had some childhood trauma, but the thing that brought her into therapy was that she had been rear-ended on the highway 3 times in 1 year. Wasn't her fault, but really bad accidents, okay? And then she developed PTSD and fear of driving as well. But anyway, what happened is as she was talking to me one day about this, and like I said before, we didn't start talking about, waited till the time was right, and then began to gradually talk about this. She started getting increasing anxiety, and she was talking to me, and then she started sort of mumbling, and then she didn't say anything, and so I intervened, and I said to her, okay, let's stop talking about this entirely. I want you to bring all your awareness to this office right now. You're not in your car. You're completely safe here. Just feel how solid the chair is beneath you, and just listen to my voice. And she settled herself back down. Okay, but then what happened was she was able to tell me what had happened. Okay, and she said, John, I swear to God, I couldn't put words together. And I said, I saw that. She said, really, I was trying to tell you something, and I got confused, and I couldn't even make my mouth work. That's what this is all about. So this is one of the reasons that we have to approach things very gradually, because you can so rapidly escalate into this overwhelming anxiety that this kind of stuff scares the hell out of people, okay? So there's another good reason for trying to do something so that you can reduce levels of arousal, so that as people are processing stuff, they don't lose their capacity for perspective and critical thinking. Okay, but the goal is to reduce arousal, but without causing central nervous system, right, depression. You don't want to put the brain to sleep. And I said before that the use of antipsychotics and use of barbiturates and use of tranquilizers may intuitively seem like the right thing to do to quell anxiety, but what it does is cause central nervous system depression, and people can't think. In fact, if you take a whole bunch of Xanax, or you drink, 10 cans of beer, yeah, you're not going to feel any anxiety, but you have created a chemical dissociation. And when people have PTSD and they start to re-experience something, they're going to usually go in one of 2 directions. Either they're going to flip out, they're going to have extraordinarily severe anxiety, flashbacks and so forth, or the circuit breaker is going to snap and they're going to numb out, they're going to dissociate. Now, numbing out in the moment is protective against overwhelm, but you don't get anywhere. You don't process anything, okay? And so chronic dissociation as a coping device does not help people recover from PTSD, okay? So this study came out in 1996, and there's been other studies that have shown the same thing. Look at this. Problems with benzodiazepine. Now, using a tranquilizer maybe once in the emergency room is not what we're talking about, but putting people on tranquilizers, on benzodiazepines for PTSD, look at this worse outcome at 1 and 6 month follow-up, and really having no effect on intrusive symptoms or reducing the amount of time spent in dissociation. And I might just say as an aside, about 20% of people with chronic dissociation slip into a state of, 20% of people with chronic PTSD ultimately slip into a state of chronic dissociation. And they may go for years without having nightmares, memories, flashbacks, or anxiety, but they are zoned out. They are zombie-like. They are walking, they're like walking through the world in a haze. And that's a hell of a way to live, okay? So it's not addressing those symptoms. So again, intuitively it might sound like the right thing to do. Medical personnel in emergency rooms oftentimes give people tranquilizers, but it's not a good long-term solution. Plus you also have the possibility of dependency, abuse, and that sort of thing, okay? There are two classes of drugs that can accomplish the goal of increasing the capacity of the nervous system to dampen high arousal without putting the cortex asleep, okay? It's the SSRIs and alpha-2 agonists that we talked about before, okay? Now, clonidine is not the only one, but it's the one that's been studied the most. The downside with SSRIs is it's going to take probably 3 or 4 weeks to start working. It's always going to be a problem, delayed onset of action with antidepressants, but in the long run can be helpful. Clonidine, on the other hand, can begin to work in probably about an hour. Okay, so there's a promise of being able to use a drug that keeps the brain awake so people can reality test and think clearly and that kind of stuff, but significantly dampening down this overwhelming anxiety very rapidly. Now, we talked about beta blockers causing depression. Clonidine can also, and it's in that same ballpark. About 8 or 9% of people that are treated long-term with clonidine develop full-blown major depression. So every drug's got some pluses and minuses, right? So that's one of the minuses with this. And so, once again, what does clonidine do? It goes down and it activates the alpha-2 adrenergic, and at the very launching pad, the source of this intense anxiety, it just dampens it down.